Sorry.
We've already started recording. So welcome everybody to the December meeting of the Inner North East London Health Scrutiny. I've had apologies for absence from Louise Ashley, who's the Chief Executive of Homerton. Welcome to Breeda McManus, who's in her place. We have a number of councillors who are joining us online, either due to ill health or transport problems. Thank you. And just to quickly run through who we have in the chamber, we've got Councillor Khan, we've got Common Councilman Sales. Welcome, it's your first meeting from the city. We've got Councillor Sweden, Councillor Patrick and Councillor McAlmont. I haven't been notified of any declarations of interest. Quickly looking at members, if there are any. The usual staple items. It's a hybrid meeting. Members of the press may be watching. Please keep your cameras on when you're presenting. Please keep yourself muted unless you're speaking. Please don't start conversations in the chat. I have been notified of one or two questions from a member of the public, which if they are joined by that, Malcolm Alexander is there. So at that point, when we come to item 5, I'll deal with those. I think that's it for my introductory items. So with that, we've got 4 substantive items today. The first of which is the ICS strategy. We had this with us before us at the last meeting. We've had a look through. I'm grateful for it being brought again. So we've got Zina to present on that as a chief exec from the ICS, and also Hilary Ross. Zina, over to you.
Great, thank you very much. I'll just do a very brief introduction and hand over to Hilary, who has done all of the work on it. As you said, Councillor Hayhurst, we came to the committee. It feels very recent. It must have been 6 weeks ago or so, I think, maybe, and talk to you about where we were at that point in the strategy. I think some of the comments you had back was, well, what's the content going to look like? So hopefully you've got more of that in front of you this evening. Since that, when we presented to you at that point, we were just in the midst, I think, or perhaps just finished doing a whole series of system-wide workshops to develop some of the content. Since then, Hilary has been busy going around Health and Wellbeing Board, partners, boards, and many other fora to make sure that this is a strategy which really does take account of as much input as possible from stakeholders, despite the very short timescale for delivering it. So I'll hand over to Hilary to take you through some of that content now.
Thanks very much, Zina, and apologies everybody. I had no sound when I logged in originally, so I've just switched machines. So hopefully you can hear me as well as I can hear you now. Fantastic. So apologies, I missed a bit of your introduction there, Zina, but I think I heard we're coming back with a bit more of the content, which is still very much work in progress, but we're beavering away, trying to pull together all of the themes that we've heard through lots of engagement. Since we last met with you, we've continued with our series of system workshops, which have been focused on our 4 priorities for the partnership: babies, children and young people, mental health, long-term conditions, and workforce and local employment.
You've frozen, Hilary.
I think we may have lost Hilary, which is bad news for me, because I will have to try and take over. Hilary, are you back, Hilary? Sorry, or shall I take over?
If she's listening, she might need to log out and log back in again. But Zina, do you want to take over while that's maybe happening?
I will do, and then Hilary can just interrupt me. So as Hilary, I think, was just in the middle of saying, you'll recall that we set out 4 core priorities: babies, children and young people, workforce and employment, mental health and long-term conditions. We also have recognised how important cost of living is as a backdrop at the moment for us as we set a strategy, and we're starting to think about that not so much as cost of living, which obviously it is, but in terms of thinking about the impact of poverty on the strategy. So Hilary, I've just described the 4 themes plus poverty.
I'm so sorry about this, everybody. It's my system is obviously worn out. So I was just going to say, in addition to all the sort of workshops that we've done around those particular themes, I've also been having discussions with all of the health and wellbeing boards locally, as well as doing a bit of a desktop review of local priorities. We've been going around to talk to people locally about what those priorities are. And I think the one thing to say is that there does seem to be a lot of alignment between local health and wellbeing priorities, accepting that there is a bit of local alignment to do between health and wellbeing boards and place-based partnerships, but there seems to be a lot of common ground for us to build on in the strategy, and certainly the cross-cutting themes, which I'll come on to in a moment if I stay connected, do seem to be resonating very much with partners locally. So in terms of developing the content, I think Zina's probably just mentioned that we've got our 4 system-wide priorities. What we've tried to set out in the current draft is a bit of a context and case for change, some of the key themes from the feedback that we've had so far, some of the priorities for system action, and also some success measures, both expressed as I statements, but also the start of putting together some more measurable outcomes so that we can track progress towards achieving those goals. And then, as I was mentioning, we've heard a lot about how important it is that the strategy talks about how we work differently as a system, not just what are the sort of priorities that we're going to focus on. And so we've come up with 6 themes that we've heard a lot about through all of our discussions over the last couple of months. So the first one is around tackling health inequalities, ensuring that our whole system is pulling in the same direction to tackle health inequalities and embed equity in all that we do. There's a theme around much greater focus across the system on prevention and early intervention, tackling unmet need, moving towards this more social model of health creation, which we've heard a lot about, progress on that locally. There's a theme around more holistic and personalised and also trauma-informed care, focused on what matters most to people, with services working seamlessly across each other and across organisational boundaries. There's a theme around, a very strong theme around co-production with local people and also partners, drawing on individual and community assets and strengths. There's something about how we work towards a high trust environment that really supports the integration that we want to see across the whole system, and that collaboration and partnership working with the contribution of all parts of the system valued equally. And then finally, operating as a learning system. So this is about sort of using data, using evidence, research, and also community insight much more systematically to drive improvement, with innovation supported, encouraged, and spread as rapidly as possible. So that's a bit of a flavour of the content. There's a couple of sections missing, so the sort of beginning bit with the introduction and the context, and then there's a section at the end which is about how we also develop the foundations of a sustainable system that is working effectively. So that piece will include things on our digital and data strategy, our financial strategy, and a bit more on equity. And we're just rapidly pulling together that final draft at the moment. The next steps are to share that full draft with the Integrated Care Partnership at their next full meeting on the 11th of January. We've already had a workshop with them to come to sort of look at some of the themes that have been emerging. We think that this is providing some clear direction for the planning round for 23-24, which includes the new 5-year delivery plan for the NHS, the Joint Forward Plan. We are going to test some of these themes and priorities and success measures further with local people through what we're calling a big conversation that we're planning for the spring. And then really importantly, we are committed to supporting an ongoing dialogue with health and wellbeing boards and place-based partnerships to continue sort of feeding into this process and moving together in an aligned way. So I'll leave it there before I cut out again, but welcome any feedback or questions.
Thanks, Hilary. I can see, so compared to the last version, I can see a lot of work's gone into it. I can see the sort of the 4 areas have become far more evidence-based, which we welcome. And I think particularly the sort of the focus on what seem to be quite tangible outcomes as well which is welcome. I suppose one sort of immediate observation on the outcomes would be they're clearly tangible and clearly could be measured, but is there a underlying document with respect to those outcomes as to sort of what the data set currently is, so you can measure it against? So for example, if we look under the children and young people, the first bullet for the outcome would be reduced proportion of babies born with low birth weight in North East London. So I suppose what is the, so we can sort of, so you can test yourself, and perhaps so we can, you know, what is the current sort of percentage on that? And I mean, I appreciate it may not be appropriate to set yourself a complete target for next year or 5 years, but is that data set there, and has it been locked down in a way that it can then be meaningfully measured against?
Thank you. So yes, I mean, you'll see that we haven't quite completed the work on success measures, but I think we've made quite a bit of progress. The measures that you've got are based on, they're a bit of a mix really. What we've tried to do is ensure that we've got health inequalities related outcome measures throughout the document. So there are some within each of the priority sections, as well as the theme around health inequalities. Other outcomes are, I mean, they're aligned to the things that we said we want to do, but we've also, I'm not sure if I mentioned the last time we met, but we've developed a population health profile across North East London, which really gives us a really good full picture of population health need, prevalence, as well as a picture around wider determinants. So some of the case for change that's in each of our sort of priority sections is drawn from that population health profile. And then, so yes, so some of the data is within that existing piece of work. So we've tried to base most of the outcomes on things that there is data for, and therefore we can track, we can develop smart outcomes and track progress against them. Some of the ones in relation to the cross-cutting themes are a bit more process based because of the nature of them. But at
the point you complete it, will you sort of lock down a data set that you will be able to judge it against? I mean, we've seen this with sort of politicians sometimes see it maybe with manifesto commitment. You know, you'd see you justify it through X, Y, and Z, but in reality, you might be picking bits that the underlying data sort of hasn't really shifted. I mean, you know, so it's really will there be a lockdown set? It may not be date, you know, it could be qualitative or quantitative, etc., that you will then judge it against.
Yes, yeah. So what we're trying to do at the moment is get a bit of a clinical view and a sort of care professional view on the outcomes as we've set them out at the moment as a starting point. And then what we will do is, as well as having these sort of longer term outcomes in the strategy, we'll also have some shorter term metrics in the joint forward plan that will show how we are making progress towards those longer term outcomes.
Thank you. Members? Councillor Sweden, do you have a question?
Oh, I've switched myself on, so thanks. Yeah, well, we're looking at a strategy which is a very broad-based document, and with the concentration on resolving health inequalities, I've got a rather broad question. Are there any implications for a reallocation of resources? And what might those implications be?
So we are, I may refer to Zina in a moment, but we are, excuse me, we are including some detail we will be including some detail in the strategy on our financial strategy. And that is going to say a bit more about how we are trying to move resources to focus more on issues like prevention and health inequalities. But I'll perhaps ask Zina if she would like to come in on that point as well.
Thanks very much, Hilary. I wouldn't say very much more that we're coming to a discussion on the financial strategy a little later, where we can pick some of that up. I mean, in order to have a successful strategy over time, or rather the purpose of having a successful strategy is over time to ensure that the resources that we use as a system are focused on achieving those strategic objectives. That doesn't imply an immediate transfer of resources, but as Hilary said, we do need to work out how we move more resource into the prevention space at the moment. For instance, at the moment we spend the vast majority of our resources sort of upstream, and we kind of need to move all of that downstream, and this strategy is aiming to help us do that. But perhaps we can come back to that question when we get to Henry's presentation on the financial strategy.
Thank you. Councillor Masters?
Hi, I was just going to ask about place-based accountability frameworks, which is a phrase I'm sort of hearing about being bandied about, but I'm not sure that this is the appropriate time to discuss it. It might be better if we've got a financial section of the meeting to discuss that later on. I don't know.
Yeah, I think we mentioned it pre-meeting. There's something I just want to. I think probably best let's pick it up under the financial item in terms of sort of the level of, say, autonomy place might have under the sort of new financial structure, if we can. I'm looking for other common Councilman Sales.
There we go. Okay. Thank you, Chair. Sorry, I'm new to this, so I'm going to ask a basic question. And it's I was quite astounded to see the figure of 31% of our residents have a long-term condition. What is the definition of a long-term condition? Apologies if it's a very basic question, but I just wonder what that actually is, the definition.
Thank you. It's an ongoing health issue. So things like, I mean, you will see in our population, things like cardiovascular disease, diabetes, a really high prevalence of those sorts of conditions, which are not broadly speaking, are not curable. So they affect people throughout their whole lives. But some of them are preventable, and we can also improve how we manage them and prevent them from getting worse. And that's partly what we want to do in the strategy. But it's a useful point to note, and as I was sort of working on the draft again this evening, I've just been pulling out things that we might need to define what we mean by. So I'll have a think about that.
Thank you. So just to follow up, who actually designates it as a long-term condition?
So I think, I mean, there's a sort of generally agreed set of conditions, which are those that are sort of ongoing. So and a GP would diagnose those with an individual. So some examples, things like diabetes, cardiovascular disease, those are some of the ones that are very, very common in our population. COPD, those sorts of things.
Councillor Adams.
Thank you, Chair. Yes, going through thank you for the presentation. As going through it, as I found out that staff retention is a big issue. So how is this strategy going to deal with that differently?
Thank you, Councillor Adams. And also, just to add on to Councillor Adams' questions, the sort of the 23% churn rate, has that increased during sort of the last few years with COVID and inflationary and cost of living pressures, or is that something that's been consistent?
So we one of our 4 priorities is obviously workforce, our current workforce, and also increasing local employment. And we've had workshops with the community and voluntary sector, with social care, and also with health partners across the system, which is all part of developing a workforce and local employment strategy for our partnership. And some of the sorts of themes that people have been talking about are about retention, the impact of the cost of living crisis on our current workforce, all sorts of issues like that. And some of the things that people have come up with are more support for our staff in terms of health and well-being, having a more seamless way of staff moving from organisation to organisation, and those sorts of things. It might be that again, other colleagues may be better placed to comment a bit more on that.
Shall I add something, Hilary? And I think you also asked about retention, Councillor, and I don't have the numbers to hand, but certainly we found that the last 3 years or so in particular have been really, really challenging for our staff, both working through COVID and then subsequently. So the sorts of things we're looking at in terms of workforce retention, as Hilary said, is making sure that we can have seamless career pathways, including, for instance, looking at enabling people to move from starting in social care to thinking about career progression through other parts of the social care and health system. So making sure that people, when they join what might initially be a relatively badly paid job, that they've got some prospects to go through, looking at making sure that our local population is well placed to come and get some really, really great jobs with us locally, looking at the range of retention schemes that are being tried across the country and making sure that we are adopting that best practice in North East London. That's just a very quick set of examples.
And Councillor Patrick.
Thank you. I just wanted my questions about staff retention and how we treat staff in a way. A lot, especially nurses, a lot of them we recruit from overseas, and I've known, speaking to some of them, that they feel not supported, that there's not a career here for them particularly. They're often given the worst jobs. We heard that with the Windrush generation, and we're hearing it again with new generations of nurses that we recruited from overseas. I just wondered how we can look at, when nurses do come from overseas to work in our NHS, how we can support them and make sure that they do get adequate support, training, and also that they're encouraged to progress up the career ladder. And also talking to nurses about how they often have to work an hour or an hour and a half, sometimes unpaid at the end of their shift, especially when they're in charge of a ward or they have to do a handover, and they tell me that they spend an hour and a half or an hour and a half doing this, and that time's is out of their shift and they don't get paid, which leads to a lot of disgruntlement. I just, we talk about staff recruitment and retention. We do have staff, but I think this, we're seeing there's a 23% turnover, and I think it could get higher. I mean, we know about the nurses that are on strike. I know that they're not on strike in any of the North East London hospitals, but I think that was more because the threshold didn't get reached, rather than any great wish that they thought they were getting, that everything was hunky-dory at where they work. So I really think we need to look at staff retention, especially nurses, which I know there's great deal of turnover. You hear about, you have to pay sometimes agency staff that cost 3 times or 4 times as much as one of our nurses, to make sure that there is adequate number of nurses. Surely if we invested the money in our own staff, then we wouldn't need to pay agency staff, which is not the agency staff, it's the agencies, I assume, get the money rather than the actual staff.
Thanks, Councillor Patrick. Hilary, do you want to?
Shall I take that one, Councillor?
Oh, sorry. Yeah, go.
No, it's not your fault at all. And actually, I think we've got Breeda on the call. So if Breeda is here, she might want to come in, particularly on the foreign nurse point. Generally, you're absolutely right, of course, Councillor. It is much better to retain the staff that we've got than it is to just rely on recruitment. And there are lots and lots of things that our trusts across North East London do and they're working really, really hard to make sure that they're able to do that. And I know all of our trusts have foreign nurses, and those foreign nurses are a really important part of our workforce. And it's really important they do feel welcome and do feel like a really important part of our workforce. And I know that Breeda has been doing lots of thinking about this too, so perhaps I'll hand over to her.
Hi, thanks, Zina. So yeah, so I think like most acute trusts across NEL, we are all doing similar things. And I think one of the big things is we're part of Capital Nurse Programme. So there's a consortium that we're involved in recruiting our international nurses, and we all recognise the need to support these staff coming in because we desperately need them. So there is a lot of movement to recognise their past experience as well, so that we're recognising that they have got many years of experience and that we're financially rewarding that. So once they get through their OSCE, then we're able to develop them a lot quicker than we did previously. So there is a need to try and develop career pathways. And I know that a lot of our international nurses are getting promoted and are excelling, and especially in the specialist areas. A lot of our specialist services we wouldn't be able to run without our international nurses. So I think there is huge recognition that we do want to continue to support them. The need for international recruitment will continue, and I think the big thing we find at the moment is for bringing our international nurses in is housing. So I would put a plea out if there's any support we can get to help support with housing when we get the international nurses in, then we would really appreciate that, especially given the cost of living at the moment. But I think there is a real drive for us to recognise their past experience, to try and ensure that we develop a career pathway for them in the NHS. We do want to retain them in post, but also recognise that we have a responsibility to ensure that they are being developed. So I think there is a real drive
and
here.
we've also got Diane.
Yeah, sorry, Zina. Zina, did you want to add anything there?
Oh, I was just going to add, hello, good evening. My name's Diane Jones. I'm the Chief Nursing Officer for NHS North East London. And we do have an international recruitment programme across North East London, and we're part of a national programme. And as Breeda said, there's a pastoral support for our international recruited nurses as well. And we have a retention programme for our existing staff, whether they're from the UK or whether they're from abroad. And part of that is recognising what are the needs that they have. And it's the social components as well. Many of our international recruited nurses talk about it's the social networks that they really want to be connected to that will make them stay and feel rooted in North East London. And so when we bring them over, part of that package of care has to include the social connections, and there are many social networks that we make sure that we can link them to and ensure that we support those networks to be able to support those international recruited staff as well. So we're actually doing quite well on recruiting international staff from areas like the Philippines. We've also looked at some of the other Asian countries. We've looked at other European and Caribbean and African countries as well. So because what we don't want to do is to take away from all those countries that they don't develop their own healthcare systems. And so it's about getting that balance between people coming to the UK and remaining in their homeland as well.
Thank you all. It's very interesting to hear in relation to that. Councillor, I wanted to wrap this item, so I will very quickly take one last question from Councilman McAlmont from Newham, and then I'll wrap it up. If you can. Bottom right button. That's it.
Thank you, Chair. In speaking about the overseas nurses, some of these overseas nurses, when they come here, housing in London and the Southeast is always a problem for those of us who live here, let alone nurses who come who do not understand the system that well. I was at a meeting some time ago where some of these nurses are thinking of returning to where they come from because they're finding it very difficult, especially with childcare. Because we live in Britain and find it very difficult with childcare. It's very expensive. So what is being done to support them in terms of childcare, in terms of their housing, etc. And one of the things that I'm also mindful of, we are depleting some of these third world countries because obviously everyone would want an opportunity. For instance, I always say that I am an economic migrant. I know that for sure, but I've also made contribution. And so people would always seek a better life. But at the same time, we are depleting some of these countries of their trained staff because most times is the experienced nurses that are leaving to come to the UK. So what are we doing in terms of supporting those countries?
So if I take that, in terms of the international recruitment programme, there are only particular countries that we can recruit from, and there has to be an agreement with that country, and then we look at between us with the levels of nursing and other medical colleagues, so medicine and allied health professionals. So we cannot recruit from particular countries where they are depleted or where there is a shortage in their own country. So there's an agreement that is put in place before we can go to those countries to advertise and recruit. The other thing to say is that in terms of people coming over here, we do, as I've said, look at the support basis, but there's also the key worker programs and also others where they will have support where people will welcome them into their homes as a temporary basis for them to be housed there. So it varies in terms of what the housing situation will be like. Sometimes the groups want to stay together, so they will work together to rent accommodation, but we do look at the key worker program to support them to get affordable accommodation.
Thank you. Thank you all. I'm going to bring this item to a close because we've got the other items on the agenda, but it's good to see the far more fleshed out strategy. I think maybe when the final document is ready, I'm not sure it necessarily needs to come back again as a sort of item, but I mean, I think we would like to see it. Just so we can digest it and understand it. So I will thank you, Hilary, for all your work. We can see a sort of a vast improvement in the iteration and the level of detail. So thank you for your work. I'm now going to move on to the next item, which is in relation to child and young adult mental health. And we're joined by Paul Kalaminas, who's the Chief Exec of East London Foundation Trust. Paul, thank you for your helpful presentation, which you've had the chance to look at. We've also had a question from Malcolm Alexander, who's on the board of Healthwatch Hackney, which is two questions. Malcolm, can I ask you to answer your two questions now, and then Paul, when he does his presentation, can maybe wrap up the answer to those at the same time.
Right. Okay, thank you very much. So my two questions were, and really the first one kind of relates to the previous item on the agenda. That is, will the NEL scrutiny give a commitment to, in their strategy, to take action to prevent, to take action to prevent patients in a mental health crisis ever having to wait more than 4 hours from decision to admit to admission to a mental health bed? And secondly, will they also give a commitment to the prevention of young people and children being sent outside their home borough for a mental health crisis, when in a mental health crisis? And the reason why I raised the first question particularly was the appalling discovery of over 100 people being held in the Homerton A&E department for over 12 hours. And it strikes me that when somebody is in a crisis, that they need immediate care. And clearly there is not enough beds in the area to enable those patients to be cared for quickly and properly. What was a 4-hour target has become a 12-hour target, which is totally unsatisfactory and is totally inappropriate for people who are so seriously ill. So, I mean, the way I see it is that people who are really have conditions which need immediate treatment are being detained in an environment which, though very caring, is not appropriate for people who have such serious mental health problems. And I really feel that that it should be a fundamental part of our commitment in North East London to make sure that we actually get rid of these long waits. The other thing is there was a question of
Malcolm, I'm going to cut you there because you've asked your questions, and I'm conscious we've got half an hour, and I want to let Paul in. So can I go to Paul, please, to both. If you could maybe go through your presentation and maybe wrap in the answer to those at the same time. Thanks, Paul.
Yeah, thank you very much indeed. Jacqui Van Rossum is also on the call, who is the Chief Executive of NELFT, who obviously provides services in Waltham Forest too. So obviously, I know people have had the chance to look at the presentation, but if I could just pick out a few key points. And I suppose the first thing to say is we are, of course, trying to pull together here information on services that are very much planned and delivered in partnership in each of the places in and North East London. So very much in partnership with local authority in terms of social care and education, with the voluntary sector, with partners in acute hospitals, and really importantly with the young people and families themselves. So within the slides, I did include a slide on actually the priorities as set by our young people. And you'll see them there, set by our young people with some input from some of their families as well. And we are really consciously trying to work to make sure that they are at the heart of what we're doing and how we are working. We've really tried to reflect in the slides some of the new services we've been able to offer. They do cut across a whole range of different conditions and ages for children and young people. Developing some of the core therapy services, some new services in terms of eating disorders and crisis, and also we said a bit about young adults. In terms of one of the questions from Malcolm, one of the elements within CAMS that we're part of is something called the CAMS Collaborative. And this is explicitly about inpatient crisis care for young people in North East London and actually North Central London. We have 4 units there. And what we have been able to say for several months now is that young people from North East London and North Central London are being treated in North East London and North Central London in our local CAMS units. They're not quite borough specific, because there are only, for example, there are only 2 units in North East London. So they're not quite borough specific, but we are able actually, and we have been able, and we absolutely are intending to continue to be able to treat people, young people, close to their home and close to their families and close to their schools. I've to pick, if you don't mind, share just a few other key points. We've said a bit about some of our plans for further service development, but it is also true that in children and young people services in particular, there has been a real impact in terms of COVID. And I included in that what is admittedly a national graph for England, but it's true in and North East London too, which is that if or as and when rather, the current long-term plan for children and young people reaches completion in 23-24 financial year, we will be seeing about half of the young people who are estimated to have mental health problems without the impact of COVID. And we do know that in some cases, the impact of COVID has created sorry, that's the wrong. The impact of COVID on young people has been really significant and has led to increases in mental health problems and presentations. And so I suppose, it's also important to say in terms of North East London, that North East London, in terms of commissioning, are spending more than the proportion that is allocated nationally on children and young people. And there are new services that have been developed as a result. But that is still, I think, a very stark graph and a really important graph in terms of how much further there is to go to actually try and meet the need that's there in the population. So we have seen some of that demand, but I did, if you don't mind, also just want to, on slide, I think 6 is in the pack. We've said a little bit about the range of work that we're doing with a range of different partners. And that includes young people themselves. It includes voluntary sector colleagues, and as I say, includes education and social care. And that's reflected in some of the work with some of the 18 to 25 age group. So we can see already services where you know, there's quite significant use and access for people in that age group. But I did think it was I did want to draw particularly your attention to, for example, the Advantage Mentoring Programme in North East, and that's something that's very much come from the community, from the voluntary sector, and then, you know, we're really able to try and help support in terms of CAMS as a service. Something that isn't readily available in really many parts of the country at all. The type of approach that we really do want to build on as we're working particularly with that group. I've said a bit in there about how we're thinking overall as an improvement network, and you can see the range, the way we're trying to think about what it is we need to do. If I finish perhaps in terms of Malcolm's question about decision, you know, time in A&E. I think the way I would think about that is I actually want to get back to a position where we always have a bed available for someone who needs it. Because you know, we have seen an impact from COVID in terms of acuity, but also in terms of length of stay, in terms of some of our community support. But the way I would phrase that is, rather than necessarily a time, is that we ought to have a bed. We need to go back to the point where there's always a bed available every night for anyone who might need it. And in that case, we will achieve time, you know, timescales and time targets. So, sorry, I think I've probably repeated too much of what's in those slides, just in trying to summarise them, but that's just really just to try and give a sense, and also, as I say, to respond to the two questions from Malcolm directly.
No, thank you, Paul. That's really helpful. So just briefly then, just to understand the sort of the wait list. I mean, I guess it will vary between borough, but what sort of wait list time for an assessment are we looking at roughly at the moment?
So for a routine normal assessment, I looked it up just for the meeting, 21, 22 days. So what's that, 3 weeks?
Fine. Okay. Councillor Brewer.
Hi. I just you know, I'm obviously very concerned about you know, the terrible experience that our, you know, children and young people are experiencing waiting for treatment, you know, long delays in A&E to see, you know, team members. I mean, how are we going to get more psychiatrists? How are we going to address this workforce issue? Because I think my feeling is we all want something better. But we've got to be realistic about, you know, how we're going to fill this gap, and how we best go about doing that. I'd just be very grateful for, you know, your thoughts on that. You know, are we going to be able to get more psychiatrists in soon, you know, and address these workforce issues? Thank you.
So I think there's a short-term, medium-term, and long-term sort of element. Absolutely. So in terms of psychiatry specifically, what we are doing is absolutely maximising our training places, and enabling those to be the route through to consultants being appointed and making sure we've got the right workforce in place. In the immediate term, in the short term, we are actually developing a whole range of new type of roles. So extended nursing roles, extended therapy roles, some of whom can actually take on some of the consultant roles. So we're seeing some of the first nurse consultants come through, for example, because one of the things I think we do need to do is as well as really trying to support the training of existing professions, is think about how we can develop new roles in that. We are also doing a lot of work in terms of developing approaches like peer support roles. So we really are trying to build teams that also include and work with people's lived experience. We've seen incredible results actually in some of the inpatient services from really working with peer support workers. They've made an enormous difference to the quality and effectiveness of services. I think, but what I also think is that we all have all in the sense of you know, all the health institutions and others working in this area do have a real job to do over the next few years actually, about really encouraging people into working in CAMS, and then really working across the whole range actually of our North East London CAMS collaborative and CAMS work streams, to create jobs that are really fulfilling and that, you know, really do create career development for people, so that we not only manage to recruit people, but, to go back to the previous conversation, retain people, you know, through their career development over the years. So I think there are some short-term things we can do. There is a role, particularly for some groups of people, for digital, and how we can use digital therapies and digital approaches to support this. But as I say, I think we also all have a job to do to really encourage and sustain those roles.
Thanks, Paul. Just following on from sort of Malcolm's point, in terms of us in Hackney had sort of a briefing on this in terms of it being a pan-London issue, in terms of people who are harmed themselves or others being brought to some of the places of safety, and the being sort of quite lengthy waits. And I think this is what Malcolm was referring to in terms of there's a 12-hour guidance that they should be, once assessed as needing a bed, they should be given one. And that's, I think, as I understand it, the whole of London's grappling with that at the moment. Are younger people being caught up in that, or can they be moved off onto a separate pathway by virtue of their age?
No, some younger people have been caught up in that. So particularly before we were in a position over the last few months where we've been able to, when we started our CAMS collaborative, we had some very long lengths of stays in some of the units, and we had young people outside North East London. We have, as I say, been able to get that back, and for the last 3 or 4 months we've been operating with capacity. So we have been able to offer young people who need an inpatient admission for CAMS have been able to get those beds. But if you look back historically, if you look back over, say, the last 2 to 3 years, yes, there have been young people caught up in that. So it remains absolutely critical that we maintain bed capacity for the young people who need it.
And I suppose just following on from that, it sort of feeds into sort of, in a tangential way, some sort of the discussions that maybe be sort of having on the whips cross design in terms of reducing number of beds, but there'll be that opportunity to flex. Well, I'm just trying to sort of drive down. I mean, do you have opportunity to flex within your existing sort of estate in a North East London or North London? I mean, is that something you're working towards, where you can deal with, where you can upscale, or are we back to staffing issues? Because even if you can find a location for the bed, you've still got to managing staff resource there as well.
It is. Sorry, Jackie, if I start, and then perhaps if you come in. It is one of the beauties of working in the collaborative, actually, is it gives us more capacity to flex across 4 units for the North Central and North East London. And the other thing, or the other intervention actually, that's creating in children and young people services particularly more capacity in that sense, is that we have a more developed, and can develop further, and can staff actually the home treatment offer. So working with children and young people at home or between home and hospital as more of a package. And the more we can develop that in effect will create more flex for us within the overall system. But sorry, Jacqui, did you want to come in?
No, thanks, Paul, and good evening, everyone. I'm Jacqui Van Rossum, Interim Chief Executive at North East London Foundation Trust. Just to add to Paul's narrative, quite often what we see in terms of delays for young people isn't what we call general adolescent beds, because as Paul said, as a collaborative, when we did our demand and capacity work, we know that we have enough beds for the populations we serve within the collaborative. The delays often come when a young person needs a bed where they're more complex and they may have a comorbidity of an eating disorder, as an example. And we did see a rise in that, Paul, didn't we, in terms of the number of young people, particularly young girls that were coming through that had eating disorders, where they need an inpatient stay, and those beds don't sit within the collaborative. And often we see very complex presentations with looked after children, so they're not kind of, not to put people in a complex or routine pathway. But when we see the delays in our emergency departments, when we're looking and trying to source a bed, it isn't because we don't have the capacity within our general adolescent units, because we do, and we work flexibly with that bed base. But when there is cases that are more complex, and particularly if they're looked after children, they're placed within one of our boroughs within inner North East London. Sorry, Paul, stopped your flow.
Thank you, Jacqui. I've seen I got Councillor Adams, and then I see Councillor Deakin. So Councillor Adams first.
Thank you, Chair. So thank you for the presentation. I was just going through the presentation, and I came across your, you talked about the access to psychological therapies and early intervention in psychosis services. However, there are young adults whose needs cannot be met by these services. I was just wondering, if their needs cannot be met by these services, what happened to them? Where did they go?
Paul, do you want to take that?
Sorry, I lost my button. Sorry, I lost my button. We have those services, and they are able to offer really quite specific age-tailored, really, support for 18 to 25-year-olds with kind of anxiety and depression in the case of IAPT, and psychosis, as you say, in terms of early intervention. So one of the things, so where do people go? So people then go to what are called community mental health teams, so the generic community mental health team services. One of the things that we are in year 3 now of in Newham and Tower Hamlets, and I think year 1 into 2 of in Wealth Forest, is some of our work on community mental health teams. So one of the strands of that is to really develop age-specific work, really work with young people, understand how to engage with them, work with their networks, and so on. So when on the slide I said we don't meet their needs, I'm sorry, I phrased that very clumsily. What I really mean was we're not offering a really tailored service from the generic CMHTs historically, and that is something we are explicitly working on, because if you look at, and partly that's because if you look at the sort of traditional or historic rather pattern of service use, traditionally in mental health services, you see relatively few people in their 20s. So one of our objectives really is to make sure that we really are developing general community services linked to GPs, linked to the community, linked to voluntary sector, etc., that do talk well to people in that age group. Because as I say, historically they're a group who've used services less, and objectively that can't be really because the need isn't there. It must be something to do with the structure of services.
Thank you, Paul. That's very interesting. Councillor Deakin, and then I'll bring Councillor Sweden.
Thank you very much, and thanks, Paul, for taking us through this presentation. I just want to pick up on the alternative to hospital admissions we were talking about. How many people are currently being supported through the at-home treatment service, and you talk about plans to look to expand that. Can you just give a bit more information about that? And then my kind of second question, if I may, I'd just like to hear a little bit more thinking about back to prevention, the plans around expanding mental health support in schools, particularly given the kind of challenging funding environment schools are facing at the moment. What are the kind of risks around your work to look to expand that, and any kind of challenges around recruitment that you may be facing in that area too? Thank you.
Can I apologise? I really should have thought to look up that caseload number before I came on this call. So can I, Chair, can I undertake to just make sure those numbers get sent over after this meeting? The teams are quite intensive, so you know, typically you'd be looking at working with 15 to 20 people in a team like that. So they are quite intensive. They are deliberately structured to try and work with people who might well otherwise be in hospital, or who are on the cusp of, you know, hospital and that sort of crisis. So I really apologise. I should have thought to look that one up. So I'll send it over. And in terms of the expansion into schools, this is a national programme, and so we're working through kind of school by school. In terms of the national programme, I don't know, Jacqui, if there's more detail on Waltham Forest specifically in terms of the next wave. But what's also true is that the waves generally don't quite cover every school. So then one of the pieces of work we will be doing, or are doing, and will continue to be doing in each of the local partnerships, is how we don't leave some schools without and some schools with, and that actually we need to make sure that in the end every school is covered, even if it's on a sort of step rollout, you know, through on a school by school basis.
Thank you, Paul. Councillor Sweden.
Thanks very much, and congratulations to Jacqui. I think you've been elevated, Jacqui, since we last spoke, so congratulations on that. My question really is about communication, and Paul, you alluded to it a bit when talking about increased support for channels of communication with GPs. And if I could just refer back to the question from the member of the public who was talking mainly about crisis. How confident are we that the backup for A&E across the piece, across the whole footprint, is adequate and working well? I know it works well in some places. And my other point is that when people are in crisis, it's not unknown for it to involve the police. And I wondered how closely we're liaising and supporting the police, who are always complaining that they have to spend a great deal of their time solving mental health problems, and the adolescent age group is probably impacts on them more. I don't know whether Section 136 works for children and young people, but it certainly works for adults. So the police are going to be involved in a major way. Thanks.
Thank you. Well, Section 136, yes, does apply for children and young people. I mean, I think in terms of work with the police, we do. Sorry, I've lost my train of thought. Yeah, so we do quite significant amounts of joint work with the police. One of the things we are looking to try and develop is to mirror some of the arrangements actually that are there for the City of London. So the City of London have a really effective what's called street triage team, where we actually have mental health professionals with the police on the street attending police calls. It's not 24 hours a day because of kind of the volume of calls and so on, but at night, you know, in the evening and at night. It's had an enormous impact in terms, of course, of how people, you know, how those situations are managed, whether people end up on Section 136 or whether another plan can be put in place. So that's an area we really do want to explore a bit further with the Metropolitan Police. So at the moment, we do a lot of work with the Metropolitan Police, particularly on Section 136. How do we work together well? and is there good accessibility for the police, and importantly within that, the police having access, for example, to crisis line numbers in mental health services, so that if they're with someone they can actually call us. We can see if they're known to services and try and help them put a plan in place. In terms of the support to A&E and the backup, if you like, I mean, there are a whole range of services, and some of the home treatment and intensive support services that are described in the slide and have talked a bit about are there and do support people, and they do support people out of A&E as well as other people who may come to A&E. It's probably important to say that the A&E in and of itself is not the main route for crisis presentations or admission to hospital for mental health. It's one really important sort of route, but the majority of people come through crisis services, crisis lines, are known to teams already. I think the caveat I would put on is simply referring back to that graph I mentioned. And you can see on that the gap between prevalence and demand and the capacity that will be funded. And so I think there is a lot more one could do, I suppose, is what I would say.
Thank you, Paul. I'm going to, because we've just hit time and we've still got 2 substantive items left, I'm going to, I don't see any more hands. I'm going to draw this item to a close. And thank you for your thoughtful work, which is clearly very sort of specific and honed, that both you and Jacqui are doing. And thank you for that presentation. I clearly think it's certainly something, just on the question from Malcolm, I think it's certainly something we were going to keep an eye on in Hackney as well, and it may be for a future meeting just to sort of get some update in terms of, for example, the 12-hour wait at the places of safety, whether the 40 beds, I don't know whether that's across London, across North East London, that are being brought online, whether that's having any impact. So it may be something at a future meeting we ask sort of for an update on where we are there, but I'll park it for the moment. So then can I then go on to the third substantive item, which is the NHS health updates. Welcome Shane de Garris, the Group Chief Exec of Barts, Breeda McManus, the Chief Nurse at the Homerton, and it may be Paul also dips into this item. We've got about 20 or so minutes for this because I'm keen to leave adequate time sort of for the financial update and side. So maybe can I go to Shane first for a brief overview from your perspective?
You can, Chair, but I thought there was a slide for NELF to NELF first in the deck, but I'm very happy to kick off if that would be easier.
Oh, sorry, I missed that, Shane. Sorry, you thought, sorry, that Breeda was going to go first with the Homerton, did you? Or
No, I thought there was an update from the North East London Foundation Trust and East London Foundation Trust. I'm really happy to go first.
I'd sort of taken it that we'd already had an update from Paul as we've been going along, and I'm conscious of time.
No
Paul, is there anything else you want to add on your update? Or no? Okay, thank you. So Shane, over to you.
Perfect, thank you, Chair, and good evening, everyone. Nice to be here. So an update on Barts Health. Obviously, actually read December, not November. At the top of the slide. Apologies for that. And then a slide for BHRT, which I won't spend as much time on, given this isn't in a North East London meeting, but it's there for completeness. 3 themes on the Barts Health slide, very familiar to councillors, no doubt, from the last discussion, and they continue to be the prevalent ones. So planning for winter, dealing with elective patients, and staffing, which of course, staffing the workforce has featured already significantly in this conversation. So that's a consistent thread. In terms of winter planning, obviously we're all concerned about pressures in the A&E departments, but some really good work going on across the system through the ICS, but also locally in each place based system. So each of my hospital chief executives are working with their place-based partners, specifically around things that make the difference locally. So discharge from hospital, numbers of patients who no longer meet the criteria to reside, and i.e. are medically fit to be discharged, and trying to have a huge push on that next week in particular, pre-Christmas, to sort of clear space for what we expect will be a lot of admissions between Christmas, New Year, and then into January. Compounding factors, of course, extremely cold weather, which hopefully will take a bit of a turn for the better next week, but nonetheless still be cold. And of course, strike action, which, although one councillor mentioned we don't have direct impact for nursing and other professions in North East London, we will have impact from the Chartered Society of Physiotherapy at some point in the new year across North East London trusts. And then we obviously have an indirect effect by the London ambulance strike in particular, which is hitting London, of course, next Wednesday, and then a date in January. So quite a lot of planning going on just to make sure we can assist the London Ambulance Service as best we can, and make sure patients get access to hospital services where they need them. On the elective front, I'm pleased to say that most of the long waiters, in fact nearly all, are gone now, and we continue to work on the next milestone, which is the sort of 78 weeks.
Shane, can you just define long waits was what? 12 or 18 months?
So 2 years was the long waiters that emerged from the pandemic, and we've eliminated those now, which is great, apart from the very odd ones that are specific for patient choice. The next milestone for the NHS is to get back to kind of 78 weeks, and then to work down to 52 weeks. On staffing, I've touched previously on insourcing of soft FM staff, facilities management staff at Barts Health, which is going very well. New staff coming on board throughout the rest of this financial year. And I've just put a little point at the end there about Barts Health team winning a discharge project around heart attack patients, which was won a national award, which was pretty impressive because it was sort of spawned from the pandemic. If I just take a few comments on the BHRT slide as well, Chair. So good progress on waiting list reductions. In fact, one of the largest reductions in London over at BHRT. Lots of good work going on through the surgical hub at King George's plus in the main hospital. We have had the Care Quality Commission into A&E over the last month. They did have concerns about the flow across our hospitals and long waits for patients in EDs. We haven't actually had the report yet. But there's plenty to do there, and plenty to do in the way we respond collectively in the system, affecting, I think as I referenced previously, lack of access to, or variable access to primary care for patients attending the A&E departments. We've touched on mental health already. You can see it referenced in that slide there. But really pleased that the system is kind of coming together to work out how we best respond to the broader issues of flow, everything from those coming to the department to those who are unable to leave hospital because of capacity. And just lastly, we can confirm now that Janine LaRosa, who's our new Chief People Officer, has started at the team, and that's a really good appointment for us. We're hoping Janine will take a big focus on equality, inclusion, and trying to address some of the issues that have been throughout the staff survey results at BHRT over the years. So I'll pause there and hand over to Breeda, if that's helpful, to pick up the acute trust updates.
Yeah, thanks, Breeda. Thanks for your slide, but we can pretty much take it as read because we've got it in front of us. Can you just maybe highlight a couple of the areas in particular? I mean, I see that the 4-hour emergency care target has fallen when normally the Homerton's, I think, one of the best in the country normally. Maybe just expand upon the reasons for that.
Yeah, I think, well, it's in the narrative there, but I think we've seen a rise in attendance in our ED, and that's a combination of pressures within the system. So I think that does impact. We have an awful lot of patient walk-ins, which is new, so it's not just coming via LAS. We also have an increase in patients walking into the department, and we do have some ongoing staffing challenges. That's both across nursing and our medical workforce. So I think a combination, just mostly the activity and the acuity of the patients coming in is related to that dip in performance. But obviously the team is working to try and relook at flow and pathways. We also had, which we don't really have, is a blockage out the back door as well. So obviously trying to get patients discharged. So the impact of them being able to kind of ensure the flow through the hospital, that is also causing a problem. And that's a number of factors. you know, obviously social care, but also when we're admitting patients that are out of area, it's more challenging to get those discharged as well. So that impacts on the ability to ensure that we're getting timely discharges. So I think it's a combination of a few things, really. So sorry.
No, you go.
Well, there wasn't really, everybody's read the rest of it, so I don't think, you know, it's just good to see that we've obviously Louisa started as our chief exec, so she's into month 2. And I think, you know, we're trying to do quite a lot of incentives for our staff. So like most organisations, we are trying to reduce our vacancy rate. So there's been a slight improvement in that. But we're also introduced the financial wellbeing programme for the staff. And as I said, we're actively involved in international nurse recruitment. We've had 70 nurses arrive since June, and we've got a planned another 40 coming over the next 2 months. So obviously with onboarding and stuff, that will take time, but that's also helping with our staffing vacancies. So I think from a staffing point of view, there are lots of things going on to help support the teams. And it, you know, like everywhere, the winter pressures are excessive. We're seeing more and more flu coming through the doors. So I think, you know, there's a combination of pressures across the system. And again, with the LAS strike, we're trying to ensure that we've got sufficient plans in place to support our colleagues in ED.
Thank you, Breeda. Just before I throw it open to questions, Shane, we obviously very much welcome the soft facilities contracts previously employed by Serco, as I understand it, being brought into the Barts family. This was something that was a live discussion in Hackney with the Homerton a few years ago, and I think they re-tendered their provider. I mean, financially, how's it working for you? I mean, are you having to swallow an increased cost of that with all the on costs, but that's something that you think is the appropriate thing to do because of all the benefits, or have you found a way to do it where you've managed cost neutrality?
Great question, Chair. I think the reality of it is it's going to cost us more money, and mainly because we're going to pay the staff comparable agenda for change rates to other NHS staff, which is the main driver for, I guess, fairness and equity for those staff compared to others. So that's the main issue. Now, we are then hopeful, of course, that having staff in-house and working together with them, we can then perhaps generate more efficiencies, perhaps than the private contractor could do. So it's going to cost us in the short term for sure, but we believe it's the right thing, and we believe over time we can probably make a difference in some of those efficiencies.
Thank you. Councillor Brewer?
Thank you. I'm glad there's been some discussion so far about the A&E waiting times at both Barts and BHRUT, because that wasn't in the initial report that was presented to us. That's my patch, and I'm obviously very concerned about it. But my question really is, here we have well below average 4-hour waits, which is a big concern. And an ongoing issue that I raise time and time again. And then we've got the Homerton doing, really quite well here. And I'm thinking, what is the role of the ICS in this? What can the ICS be doing in terms of sharing that best practice so that we don't have this disparity, that we can, so that's really my question. What can that role be about making sure that we kind of don't have this situation where we see, one performing well, one not so well. So that's that. I don't know if I can have a response with that. Thank you.
Thanks, Shane. I think Shane, I asked a similar question last time, and I think you answered. I'll let you see if my memory's right.
Well, let me kick off with that, then perhaps bring in colleagues from the ICS who might want to comment from a more broader point. I think that it's difficult, this one, because the short answer is we do compare and share best practice from the Homerton and others. In fact, the lead consultant from the Homerton, Dr. Emma Rowland, is the lead for UEC, urgent emergency care, across North East London for those reasons. So there's definitely sharing of best practice. It's difficult, though, to compare like-for-like A&E performance, because actually the Homerton has a lot less ambulances than, say, Queen's Hospital has. And the nature of the support in primary care and in the community is significantly different in Redbridge or Havering or Waltham Forest than it is in Tower Hamlets or City and Hackney. So there's quite a bit of variation there. I think also the other point is the hospitals that occupy the so-called outer ring of London, the sort of outer donut of London, are all the ones traditionally that struggle with A&E for various reasons that are pretty common around the Greater London capital. So we do work with the Homerton. As I say, their clinical lead is heavily involved with us. There's quite a lot of shared practice across, but where we can learn more, we will. Lots of the things that they do, we've implemented it at most of the hospitals. And at the moment, this is all about making sure patients get the best possible flow through. But when you've got a hospital or hospitals that are completely full of patients that we cannot get out of hospital, inevitably that blocks up the A&E department. So there isn't a hospital that's hospitals that don't have lots and lots of patients waiting to go home tend to do better also in terms of A&E. There's a direct correlation there. So I don't know whether ICS colleagues want to add anything to that.
And I'll come in briefly. I mean, Shane's said much of what I would have said, and of course, the work of our collaboratives, including the acute provider collaborative, are intended to share that best practice. You know, understand where there is variation, which is for good reason, and understand where there is unwarranted variation, and take action to tackle those. I guess the other 2 points I would add is just building on Shane's point about the specifics of the different sites. Queen's is I think the 4th busiest emergency department in London and 12th busiest in the country. So it is a very, very busy ED. And that's just slightly different context from the Homerton. And the other important place where we learn from best practice is kind of the whole of the rest of the system. So I'm sure Breeda and others from City and Hackney could talk at length about the work that they've done over many years, working with local primary care, community services, with the council, you know, the kind of work that they're doing now to embed neighbourhood working. And those are really important initiatives in reducing the number of attendances at ED, and historically probably the reason why the Homerton has a lower proportion, or one of the reasons why the Homerton has lower proportional attendances than some of our outer London hospitals. So it is about that whole system working.
Thank you. I think I want to leave enough time for the financial item. We've got a few minutes left, unless I see any other particular questions from members. Shane, just on the BHRUT side, in terms of the CQC inspection, in terms of those recommendations, I mean, what are you expecting there? You've had initial feedback, and they've made what initial suggestions prior to the report being published that you're putting into place?
Yeah, that's correct, Chair. In fact, there's actually they've said that the departments are just too congested, so they've asked us kind of what can we do. There's some immediate must-dos in the gift of the hospital, but more broadly, they've asked the system leadership to come together. So myself, BHRT, Zina and her team, Jacqui Van Rossum and the NELF team, that's going to be a meeting next week. As they call it, a quality summit with NHS England as well there, just to talk through what the CQC have found and then how we can work together across the various issues. So covering the whole pathway. And to be fair, that sounds like a good approach to me and to Matthew Traynor and Chief Exec over there, because it does imply that we need to work on this together to deal with what is a multifaceted issue that has bedeviled Queen's and King George's for many, many years. So we'll be able to feedback more when we meet next time, Chair, because I said the summit is next week.
Thank you. I think I am going to draw that then item to a close, so we can move on to where we are with the finances and sort of the understanding about how that's going to work with the ICS. So I'll draw that item to a close and then go on to the last substantive item in the agenda, which is item 7. We're joined by Henry Black, who's the Chief Finance Officer. Thank you, Henry, for a very helpful presentation, setting out sort of, as we'd asked, sort of like the position across the different boroughs and how it's changing and how it's broken down between primary and acute, and also what sort of the plans are going forward. So I'll obviously let you present. I think as I've sort of, the other aspect, I suppose, to this is just to get an understanding is that in the new system that will come into place in April is to what extent will the different places have the, I suppose, the staff resource to be able to make and research their own sort of funding decisions vis-a-vis all that staff resource being held up at ICS level. As I understand it, that might still be a live conversation that's going on. And I think papers went out to different, we haven't seen them. I'm not saying we should see them, to the different sort of health boards in the last few weeks, but starting off discussions. But it's just sort of what assurance can you, I suppose, give us in that regard that the different places will be able to sort of have staff to be able to make decisions on funding it in their area. But over to you, Henry.
Thank you very much, Chair, and thank you, committee. My name's Henry Black. I'm the Chief Finance Officer for NHS North East London. So, as has been said, the slides in the pack should set out where we're at and what we're trying to deliver with the financial strategy. But just before I go into the detail, just by way of a bit of context, the first couple of slides, as Councillor Hay has said, set out the kind of any changes from 21-22 to 22-23, and just give some assurance around the kind of stability of funding at place. But I guess it's just worth describing or explaining a bit more of the kind of environment in which the health and social care is kind of operating now, and the quite profound change with ICSs from what we had before, which was the NHS and social care working very, very separately, and within the NHS, the kind of the internal market, which was largely kind of incentivizing competition rather than collaboration, and how the ICS is very much about working collectively together, and the provider collaboratives and the place-based partnerships working as genuine partnerships between health and social care and the third sector. And so the financial framework is about designing a way of making the funding work much more effectively at that place level. So I'm not going to go into too much detail because it's in the slides, but just to pick up your point, Councillor Hayhurst, about the resources at place, because it is a really, really important one. And I think it relates in some ways back to the accountability framework, which was mentioned earlier, and that is something which we are developing. The place-based partnerships it has to be kind of recognised that they are brand new entities. They are non-statutory committees which sit within the single statutory body of the ICB. But the ICB obviously has a board which is made up of much broader members. So we have health and social care, we have Councillor Maureen Warby from Barking and Dagenham, and we have Mayor Phil Glanville from Hackney as full voting members on the board. So the place-based partnerships are also much broader kind of committees than we've had before previously. So they will take some time to develop and to kind of mature in terms of their priorities and their thinking. The resources that they need to deliver that are, you know, that is a really key point that we are addressing. There is some aggregation of kind of back office functions at the single North East London level, and that's what you would expect to be able to make kind of economies of scale and best use of specialist skills. But we're working hard on how a kind of business partnering model that supports place-based partnerships, but also how the direct resources that each place needs to deliver are put in place. So we have 7 borough delivery directors who are, they're not all in post yet, but they are senior roles at a place level, and they will have their own teams that are embedded within the place and that have business partners from back office functions around analytics and finance and the other kind of support functions. And that model is emerging. But the core kind of principle around the mutual accountability framework is around subsidiarity as the main principle, and as far as we can, we are working through how those place-based partnerships operate in a fully autonomous way. The financial framework will give those place-based partnerships full kind of responsibility for the majority of the budgets. We're looking at the acute budgets being held by the acute provider collaboratives, and the mental health by the mental health collaboratives, but everything else effectively going to place. And within the place-based partnerships, there will be representatives from those collaboratives on each of the partnership committees, and there will be full visibility of the entirety of spend at that place. So there will be every opportunity for those partnerships to make decisions about shifts of resources within the pathway, and the kind of proper profiling of resources at a place-based level. The other thing that the financial framework is trying to do is secure the funds to support investment in prevention and early intervention. We are looking to effectively ring fence 1% every year of the growth that we will receive annually every year from the NHS settlement, and use that money to invest where we can in prevention, early intervention, and other kind of upstream functions. And that would be at the kind of discretion of each place to determine what those priorities would look like for each of the communities that they serve. So I'll stop there, Chair, and I'll take any questions.
Thank you. Just before you do, can I just do one other matter, sort of like an intro? I should have said at the start. Where are we with the deficit that we were this year? I think was on the sort of the board papers was roughly around 1%, 40 million of your budget. Has that been brought more under control? Has it grown? I didn't quite get to the bottom of. I think the Health Service Journal sort of reported we were in a North East London had the highest figure. I didn't know whether that was in real terms or percentage. Could you just give us an update there on that aspect, and then I'll throw it open.
Yeah, sure. There was some slightly some reporting in the press which I don't know, it wasn't quite necessarily reflective of where we're at. But anyway, so the position as at month 8 is very similar in North East London to the rest of London, to the rest of the country. Everywhere is financially challenged. The overall NHS England kind of position is in balance if you take into account central kind of national reserves. But we're in discussion with the NHS England team around where we are going to be able to land by the end of the financial year. We think that a deficit of around 30 million is going to be absorbed by NHS England, and we should be okay to do that. This is still kind of in discussion, but that kind of reflects the fact that there is a very clear stabilisation of the run rate in the second half of the year. So a lot of that cost is quite consistent across the country, where there has been significant costs of COVID overhang in the first half of the year that has now been largely stabilised in the second half of the year. So we should be going into next year's financial kind of settlement with a reasonably stable run rate. But that's not to say that next year is probably going to be one of the most challenging years we've ever faced. And it goes without saying that the cost of inflation, the cost of living crisis, and everything else is creating enormous pressures on health and social care budgets.
Sorry, I don't want to be too crude about it, but would we? See, I don't think it's in any of our interests. I'm being quite crude here, for North East London to be the worst, either on percentage or real terms.
We're certainly not the worst, no.
Fine, okay, all right, okay, fine. Can I mean, I've got several questions, but I'd sort of throw it open to members to start with, and then I can maybe go to Councillor Masters.
Thank you. I'd like to know a bit more about these local accountability frameworks. I mean, it's a term I'm hearing sort of bantered around in Hackney, and I'd just like to understand more what this actually means and what the impact's likely to be.
Shall I take the questions as they come?
Yeah, please to start with, and then
Okay. So I think this is something we should probably bring back to a later meeting, and the reason I say that is because it is very much in development, and we are trying to co-design this, and it is a mutual accountability framework, and the intention is to kind of have that as something that works in both ways effectively. So as I said before, the North East London organisation, that the ICB is the kind of the statutory body, but the place-based partnerships are really where the kind of the partnership work and the real you know, the real work close to the community needs to happen. So that kind of what happens at a North East London level and then what happens at a local level, there is that kind of that mutual accountability between those two. So it is very much being developed as we speak. And the principles are around that subsidiarity, but around how you know, North East London has 4 billion budget, and clearly the requirement to reduce unwarranted variation and to close the gap of health inequalities is our fundamental purpose. So how we kind of support the place-based partnerships, but also it's important that we hold, you know, that the ICS holds place-based partnerships to account for delivery of that. And that accountability, like I say, it works in two ways. So that is still being developed. It's being developed with local communities and with the kind of all of the partners within the place-based partnerships. But it is still in a kind of work in progress.
And so, building on that, what's the sort of, you know, and I appreciate the point you made before, that the whole nature of ICS is coming from above, is that, you know, you presumably meant to show some savings through greater sort of working together, and so there's some pressure on you, or understandable duty on you to do so. But I think from what you're saying, there's probably an understanding that you want to probably commission as locally as you can, and you've got to try and balance those two. But roughly, what are we talking about in terms of resource? So to take City and Hackney, for example, I think, not 100% sure, it's got roughly about 26 full-time equivalents in terms of staff. So roughly, if we were to use that as a proxy, what are we talking at? What ballpark are we in for how much of those 26 full-time equivalents would be at place level vis-a-vis ICS level? Are you able to give us what sort of weird? Are you just going to give them one member of staff? Are you hoping to give them 12? Or I'm not going to hold you to it, and I appreciate it's going for discussion. Yeah. But what sort of resource are you planning to give to place, to use that as an example?
So I mean, I'm not going to give you a number because you've given me that get out, but it is so it's one senior member of staff is a very senior director, and then there will be a team to support that, and the balance between how a team functions, as a separate team locally, how it is then embedded as joint teams with each of the local authorities, that will be different borough by borough and partnership by partnership, but certainly it will be a balance, and I'm not going to say absolutely 50-50, but it's not going to be massively skewed one way or the other. We wouldn't want to delegate, every resource down and have no ability to generate those economies, but equally we wouldn't want to hold everything centrally and have no local kind of flexibility and ability. So it's going to be somewhere in the middle and not kind of skewed one way or the other. But they are still, it's all still in development. So we will bring something back.
Zina?
Thank you. I just wanted to add, Henry's very diplomatic answer. I will just add slightly to, which is there will absolutely be a core team in place. Henry's already mentioned having a very senior member of staff. So for each borough, there will be a delivery director. As he said, it varies a bit depending on whether or not they are an NHS member of staff or jointly employed across local authority and NHS, or in some cases slightly different arrangements. And that's entirely appropriate because that's building on the partnerships that already existed. In addition to that, we've also appointed a clinical director for each of our places, and there'll be somebody clinically specifically responsible for primary care improvement. And so those additional two posts, the clinical director and primary care improvement, I think are also really important, really quite significant resources to mention.
And just take another. Sorry, I'm in danger of monopolising. Members' questions. Any Councillor Adams?
Thank you, Chair. On page 39, you said, there's a statement that said that the system is facing significant financial tightening with unfunded inflation and removal of COVID funding already creating pressure on most tightening expected across the whole public sector. So I'm just wondering, where are you at the new settlement for 2023-24? That's one of my questions. I just want to know how are they dealing with that. And the second one is that on the same page, there's a mention of a new financial framework being developed, moving from over time to a population-based financial planning and funding approach. I'm just wondering that what's wrong with needs? Because people are not talking about needs here, you're talking about population. You might have a bigger population and your needs might not be as big as small people with small population or the borough with small population. I don't know if that makes sense.
Yeah, so I'll take the second point first because it's probably just the clumsiness of my wording. I mean, population health approach does effectively mean that it's based on the needs of the population. It's intended to describe that rather than what we've had in the past, which is effectively hospitals being funded based on the volume of work they do, regardless of the kind of need or the population that they serve. And that's a very crude and sounds slightly pejorative on hospitals. It's not meant to, but that's how payment by results worked. It didn't matter who the patient was or where they came from or anything else. It was all based on volume driven activity based funding, and that's how it used to work. We're trying to move away from that where we can, whilst ensuring that we maintain stability, of course, and ensuring that our hospitals are funded for their costs. But that funding should be based on a better reflection of the populations they serve and the needs that those populations have. So that's slightly clumsy on our part, and it should reflect that need point. In terms of the financial constraints, I mean, it goes without saying that the whole public sector is facing enormous challenges. The global kind of financial environment we're in with hyperinflation is challenging, and Barts Health in particular this year have a big issue on hyperinflation around utilities and the PFI and other factors which are part of our financial challenge. We don't actually know yet what our financial settlement is for 23-24. We're expecting to receive that on about 5 o'clock on the 23rd of December, so before we all break for Christmas, which is the kind of traditional NHS England early Christmas present. But we don't expect it to be an inflation busting uplift. It's going to be very, very tight.
Does that cover Councillor Adams' first question as well? Yeah, definitely. Fine. Okay. Councillor McAlmont.
Thanks, Jim. Did I hear you say that NHS England is likely to write off a 30 million deficit?
So essentially, to all intents and purposes, that is how NHS funding works. The NHS has a whole government accounts for its entirety, and that some parts of the NHS may overspend in year, and some parts may underspend in year. And as long as that is worked through nationally, through our regional team, and then up through nationally, there is a kind of set of agreements that balances that off. So broadly speaking, yes. I mean, from an accounting perspective, the organisation that makes the deficit has to record that on its balance sheet, and so it becomes a recurrent kind of issue. But it's not the same as a business that has to pay it back or to go into debt effectively.
So, in other words, there's no actual incentive not to incur those deficits.
Well, the incentive would be that organisations and systems go into financial special measures, and that can be extremely onerous and challenging. So there is a requirement for systems to break even, but for context, 30 million is about 3/4 of what, so it's less than 1% of the total budget, and we will be expected to land a balanced budget next year again. And that happens every year.
Okay, and just one more question. So do you have any strategies in place to make certain that the outcomes are balanced rather than entering into deficit? And I must say, I did work it out that is less than 1% or thereabout, which is good, but then obviously one should come in on a balanced budget. So what are the plans?
Yeah, so we have short and medium and long-term measures in place. So the short-term measures are that at the halfway point of this financial year, we were actually already in a deficit of about 50 million. And if you extrapolated that, we would get to about 100 million. So the improvement in our run rate in year from the measures that we've taken has already had that effect. So we you know, that's the kind of short term. And then in terms of the medium and longer term, we are working through the financial strategy that we've talked through. It does look at how we make better use of resources, how we rebalance our expenditure into prevention and early intervention to reduce the demand for downstream activities and hospital activity, which is more expensive. That's a kind of very long-term proposition, but other than that, we will always make cost improvement programs and efficiencies. Every year we will implement a whole range of cost improvement programs to bring ourselves back to balance.
Thank you.
Just on what you're alluding to before in terms of the model away from payment by results, how does this fit with, I think it maybe just be what we're hearing in the media about possibly a return to payment by results, or am I misunderstanding?
No, you're not misunderstanding at all. And as we have developed the strategy, that was on the basis of an expectation that we wouldn't return to payment by results. Now there is a growing kind of sense that might be on the horizon. It's not definite, and it won't be payment by results in its previous form, which was a pure volume activity driven measure. There's likely to be some incentive, which is the right thing to do up to a point in terms of incentivizing systems to reduce long waits. And so on the elective backlog clearance, it is important to divert resources to support that. So we're yet to see exactly what that does look like nationally, but we are assured it won't be a return to the old days of everything being volume driven. But there is likely to be some aspect of volume coming back in, yeah.
Of course, the problem with that is it slightly counters against sort of all working together. If every hospital is trying to protect its volume.
Yeah, it absolutely does, and we are worried about it. I mean, I'm going to be ever upbeat and say that what it will do is make it easier for us to shift resources around where we have mutual aid and the kind of high volume, low complexity stuff, which actually makes sense for patients and helps reduce the waiting list. So, in some cases, being able to do that by shifting the money to where the patient is will help. And we're going to resist a return back to the bad old days where it was all about trading between organisations.
And just in terms of sort of what your early Christmas present and what you referred to in terms of the uplift, I was looking at sort of page 36 in terms of, say, the increase of what was a 3.4% increase between 21-22 and 22-23. Obviously, there's an inflation aspect. There is also a rising population aspect, and it's just trying to understand that 3.4. I mean, it could be a real terms decrease if you take into account our growing population. So I'm just trying to, how do you cut it? How do you understand it when you had that 3.4% increase, but actually the population may have increased? So per head, will we still up that year, or?
So I suppose there's a couple of things. So firstly, on a like-for-like basis, it probably is a real terms cut, and that's the nature of public sector funding. Particularly if you take into account the hyperinflation that we've had this financial year, and that's why it has been so challenging. I would just give a slight caveat, which is that 21-22 was a very high year for additional COVID money that was given over and above the kind of standard allocation. So that was in 21-22, and it then reduced in 22-23. So that 3.4%, if you strip out the reduction in COVID, was probably a slightly higher, more like 5%. But it is, and we don't know what the settlement will be for next year. We suspect it's going to be something quite similar. So we will again see a further reduction in the additional COVID money, and then a separate uplift for population and inflation. And my bet is that it will be somewhere around 2.5% to 3% once you've taken both of those things into account.
And just staying on that page, on page 36, in terms of sort of like what we see as the breakdown of funding for the different boroughs, roughly which line items would we be looking at then that would roughly get devolved down to place? Obviously, you've said about the acutes and in terms of the mental health acutes. So would it be more in terms of sort of the community aspect and primary care aspects that would be the sort of the chunks that would get devolved down to place?
Yeah, absolutely. It would essentially be everything else other than what would go to the acute collaborative and the mental health collaborative. The community services we have community services provided by community trusts or by in Elfton, Elft in some of the boroughs, and Barts Health and Homerton in Tower Hamlets and City and Hackney. And the community health collaborative, which is a separate collaborative but is not quite at the same degree of maturity, is so the community services budget sits better with place-based partnerships as that kind of wraparound out of hospital resource. So effectively, everything apart from acute and mental health will be within the place-based delegated budgets.
In terms of the accountability and the financial frameworks you're working on, I mean, I appreciate the live discussions, but at the point that you sort of settled on something, how open are you keeping it for it to be an iterative process? Okay, this isn't working as well. You're getting a lot of feedback, but this can be tweaked so that it can be a continual review the following year where you haven't sort of really put markers down and made it difficult as a process to make tweaks or maybe quite substantial changes if the evidence is showing that that's what's needed.
Yeah, I think that's a really, really important point, and it's one of the benefits of having a single statutory body across North East London, but then non-statutory committees at the place-based partnership, because it means that we can make those changes, and the mutual accountability framework will be a key kind of part in how that works, so that both, as I said, it would work both ways, and the expectations would be placed on the place-based partnerships, but equally, if the partnerships feel that there is a better way of doing things, we can change that by mutual agreement, and it has that flexibility to do that. So we will certainly not try to land this on a sixpence at the first time of asking, because these things will evolve and iterate.
Councillor Masters.
Thank you. I'm just slightly worried about the idea of our local hospital being kind of yanked out of that place-based partnership. I mean, I fully accept the fact that, if we're looking at it from a Newham perspective, Newham Hospital is part of the Barts Health Trust, but surely one of the things we've learned is the importance of place factors within acute care. And I'm just worried slightly that by placing that more within an acute collaborative than a place-based partnership, we might actually be missing part of our own sort of very place-based jigsaw.
Yeah, so a couple of points I'd make. Firstly, the Homerton is a full member of the City and Hackney place-based partnership, and Louise is the kind of the lead for the partnership itself. So the Homerton play a huge role in the City and Hackney place-based partnership. There will be full visibility of all of the spend, including the acute spend, at the place-based partnership. But the direct accountability is for the out-of-hospital and community budgets, with the acute sitting with the acute collaboratives. That's the intention. But I mean, as we've said, that will need to evolve and will need to work in the way that the mutual accountability framework effectively binds the place-based partnerships and the provider collaboratives into a kind of mutual accountability. That's the intention of that. But as I say, the Homerton are a core part of the place-based partnership for City and Hackney, will be full members of that group, and so that which is a big step change from when we used to have single borough or the borough and the City of London CCG, which was a statutory commissioning body, which meant that the Homerton was well and truly not part of that decision-making governance, that committee. So the place-based partnership is a very different animal in that sense.
Because I mean, I suppose it goes back to the point in a way that sort of that Shane and the way Breeda was talking about the more recent problems the Homertons had in terms of discharging at the back end, because you really, yes, I mean, how do you make sure, because it's so interlinked in a way in terms of if the place-based partnership is doing well, it's stopping people going into A&E, and if it's doing well at the back end in terms of working with local authorities, you're helping the flows out of the hospital. But it's really tough. You are on a structural level, you are taking the hospital out in a way by having that top-down funding, aren't you? I mean, it's a real balancing act as to how you maintain them having a vested interest in place.
Yeah, I mean, I would go back to the point that the Homerton is a member of and a lead member of that place-based partnership. So yes, there will be. It will be important that we have the right kind of mechanisms in place for that mutual accountability between provider collaboratives and the place-based partnerships. The City and Hackney place-based partnership with the Homerton around the table will be able to make decisions about shifting resources from one setting to another by mutual agreement. But certainly the Homerton will be a much more direct decision-making kind of partner within the structure that we're proposing than it ever was able to be as a single borough CCG.
I think the Homerton's got that advantage. I mean, the Homerton is standalone. I mean, I'm talking more about the hospitals within the Barts partnership that are part of that larger provider collaborative that's outside of the place-based partnership in your model. But you know, to us in Newham, our local hospital is very much a body we want to be integrated with, and that has to integrate with our sort of local system. And I think the very fact you've picked up on the Homerton as your example of how it can sort of work at place just illustrates the very point I'm concerned about, that, you know, the Homerton is standalone, but, you know, Newham's part of a much larger trust that is now a lot more closely linked with another large trust. So I just think there's far more challenge involved in that.
Shane?
Yeah, no, it's really good points being made here. I mean, I think just to clear what we're saying and what we're not saying. So Newham Hospital is absolutely part of the place-based partnership. You know, where the budget sits to some extent it is easy for the Homerton to some extent, but Newham Hospital is very much part of that partnership. I mean, there's a question about what happens here over time. I mean, you're going to remember why places like Newham and smaller hospitals were put in part of a group in the first place. I mean, on its own, it would not be financially solvent with the current level of patients it kind of has. So it's in our interest and in Newham Hospital's interest to have less work at the hospital and more in the community. So I think over time, there's a chance here, because we talk about medically optimised patients, discharge, patients coming to hospital, the more we can keep people at home and services are better for them, the more some of that spend can be redirected to the community, be it primary, community care, whatever. So that's the ambition. But so the hospital very much is part of that place-based partnership, although I appreciate your point that the budget itself still sits within Barts Health overall.
And sort of how much the local authorities, I mean, you can sort of say, oh yeah, they are, you know, through the elected members being in certain positions, but I'm talking about their sort of core adult social care function that makes such a difference to hospitals' discharges. How much are they being wrapped into the place with a vested interest? You know, to take an example of, say, where City and Hackney were trying to go, was trying to look at more of a real joint commissioning in terms of budget with adult social care and the CCG, and really trying to drive that forward as a, you know, the Hackney pound, you know, just for the Hackney healthcare system. Are we bringing in thinking about adult social care budgets and joint interests in this as well? Is that at centre?
Yes, very much so. Yeah, I mean, the place-based partnerships, the very nature of the place-based partnerships is that they are partnerships of health, social care, and within health, providers and commissioners, which is you know, this is the kind of fundamental difference between what we had before in the old world of individual local borough CCGs, where there was just a commissioning body that providers were excluded from that decision making process, and local authorities were kind of slightly on the sidelines. In some areas where there had been joint commissioning arrangements, that was much more mature, but it wasn't the kind of core model. So the purpose of a place-based partnership is to bring all of those partners around the table and to have that committee where you have providers, commissioners, local authority, local government, and the third sector all around the same table with the same kind of vested interest of that end-to-end pathway. So that is the core kind of principle or the core purpose of the place-based partnership.
We'll draw it to a close unless there's any other council questions. I mean, there's one other thing is how do you just ensure, I mean, previously under the CCG framework, obviously they were essentially the funders of their of the acutes. Here they're not, with all the pressures on the acutes. They're the ones that are more likely to have the runaway budgets possibly through no fault of their own. How do you? You're under pressure to keep it under. Go back to Councillor McAlmont's point about you're under enormous pressure to keep it in budget for the fear. How do you not make sure that the acute don't start swallowing up more and more of the budget, or just having to take more of that top slice money that you wanted to do for elsewhere? But you've got to stay, you know, I appreciate the pressures you're under. You've got to stay into budget, and then suddenly you're top slicing, but it's got to go and backfill in acute spend. I mean, how are you? What's your strategy to battle that problem?
I mean, it's an excellent question, and it was, you know, that what you've just described is the perennial balance that we have to make in the NHS around the extent to which, you know, we devolve and ensure that there is local autonomy versus maintaining that financial grip and control. Having a single ICB as the statutory body and then having local devolved place-based budgets that's the attempt to kind of have that balance to ensure that both of those things are kind of are met, and having the acute budgets in one place where you can then have that kind of economy of scale and that sharing of risk in one place is part of that kind of financial grip piece.
Zina?
Yeah, I was just going to add to that. I mean, that is fundamental, or one of the fundamental reasons I think ICSs have been set up, particularly given, you know, bound in with that funding cycle that you've described, Councillor, as some real health inequalities that get baked in. And I'm sure Shane and other acute colleagues would agree that the kind of way that funding is currently working is not sustainable, because kind of demand is going up and up. And so, and the money just doesn't exist, or capacity or workforce doesn't exist, or physical space in the hospital buildings, quite apart from anything else, to kind of carry on that path. So if we don't collectively find ways of kind of pushing the funding upstream, investing further upstream in prevention and community support services, then, you know, we're just going to be in an unsustainable place. And the way we're setting up, or starting to set up, the place-based partnerships and others is our best guess at how we do this. But as you've illustrated collectively, councillors, through your questions this evening, this is a really complex process, and we're going to be learning as we go.
Going to thanks for that. I mean, it's helpful for us to understanding where you're at, and obviously I appreciate some of the live discussions, and I think as Henry's already indicated, maybe at the point when you've reached a more concrete position with the two frameworks, the accountability and the financial one, it may be that they can then be brought back. To us, once you've reached that, possibly with a sort of greater clarity on what it means in terms of what sort of staffing each place gets, and I think also important things like where are they based? You know, are they based centrally with you? Are they actually based? Because obviously that matters as well. I think my camera's just gone. staffing each place gets. And I think also important things like where are they based? You know, are they based centrally with you? Are they actually based? Item 8, Whips Cross. Any news, Councillor Sweden, or are we where we were last meeting?
Well, we met on the 2nd of November, which I think is subsequent to our last meeting, and.
Councillor Sweden, or are we where we were last meeting?
Well, we met on the 2nd of November, which I think is subsequent to our last meeting, and. Well, we met on the 2nd of November, precise pro forma. There are 2 other people online who were also at that meeting who may be able to fill in additional details or correct any errors that I made.
Councillor Brewer, sorry, I'm looking at time. If there's anything else briefly you wish to add before I close the meeting?
Yeah, certainly. I mean, obviously massively disappointing that the major project review group, Lord Markham, you know, that was 6th of December. Lord Markham said the timetable will be released at some point in the new year. Goodness knows when this point in the new year is going to be. But after the fanfare announcement that we were going to get a new hospital in September 19, at some point in the new year, 2023, is obviously massively disappointing for the community. And massively disappointing for its local representatives. So I'll just end on that. Thanks, Chair.
No, noted, and thank you both for your work. And I'm sure the frustration is shared by all the health professionals as well.
Yeah.
Can I take minutes last meeting agreed, please? Thank you. Work progress at the back of the agenda. I haven't been notified of any other business, and with that, I close the meeting. Thank you, everyone. Thank you.
Thanks, everyone. Good holiday.